Imagine a medical condition so rare that back in 1971, there were only maybe 500 documented cases. Ever.
Yeah, and even by the early 80s, that number had barely doubled. Just shows you.
We're talking about something really uncommon today. Carotid body tumors. Welcome to the deep dive.
Uh-huh. Where we try to boil down the complex stuff for you.
Exactly. We're wading into the specifics of these carotid body tumors.
That's right. We've gone through the relevant chapters in Rutherford's Vascular Surgery and Endovascular Therapy, the 10th edition.
Yeah.
Really authoritative stuff.
So this is like your shortcut to getting up to speed on this specific, pretty obscure topic.
You got it. And because it's so rare, historically, I mean, for decades, a lot of the understanding was just based on, individual case reports.
So not big studies. Made it hard to agree on the best way to treat them, I bet.
Precisely. Consensus was difficult to reach for a long time.
Okay, so let's start at the beginning. What is a carotid body tumor, exactly?
Well, the first person to really describe it formally was von Haller, way back in 1743.
Wow, okay.
And what's really interesting is that as far as we know now, these tumors are basically the only pathological condition, the only disease that specifically affects the carotid body itself.
Huh, just this one thing.
Seems like it. And because they're so uncommon, like we said, it was historically a real challenge to figure out, how they behave, how likely they are to turn malignant.
Right.
It actually wasn't until 1903 here in the U.S. that the first successful surgery to remove one was done by a Dr. Scudder.
1903. So we've known about removing them for over a century.
Yeah, but here's the kicker. Even with all that time and tons of medical literature, there's still ongoing debate. Different opinions about the best way to manage them.
Still, after all this time.
Still, that rarity factor means we're constantly learning, still refining the approach. It's like a puzzle that keeps evolving.
Okay, so given how rare they are, do we know who gets them? Are there specific risk factors or causes?
Well, pinning down the exact number of new cases per year, the incidence, is really tough. We just don't know precisely. But we do know they're most often diagnosed when people are in their, say, 30s to 50s. That seems to be the peak time.
Oh, okay.
Although, if it runs in the family, if there's a family history, patients might actually present quite a bit younger.
Ah, the familial link?
Right. And there's been some talk, maybe a slightly higher prevalence in women. But honestly, the studies on that are a bit conflicting, not totally clear.
Gotcha. And you mentioned types.
Yeah, we generally put them into 3 buckets. There's sporadic, that's the most common, just pops up seemingly randomly.
Okay.
Then familial, which might be up to, say, 10% of all cases. That seems to be inherited, autosomal dominant pattern usually.
Meaning if one parent has the gene.
There's a good chance the child could inherit it, yeah. And those familial cases often show up younger, like I said, and they have a much higher chance of being bilateral, meaning tumors on both sides of the neck.
Oh, wow. How much higher?
Maybe up to 30% bilateral in familial cases compared to somewhere between like 2 and 20% in the non-familial sporadic ones.
Big difference. And the third type?
The third type is called hyperplastic. These aren't really true tumors, not neoplasms in the classic sense.
Okay, so what are they?
They seem to be more related to prolonged hypoxia, low oxygen levels over a long time.
Like living at high altitude.
Exactly. High altitudes or people with chronic lung disease like COPD or certain heart conditions that cause cyanosis, that bluish skin tinge from low oxygen.
So the body's response to low oxygen might somehow trigger this hyperplasia.
That's the leading hypothesis, yeah, that chronic oxygen deprivation plays a role in their development.
Fascinating. And the genetics you touched on earlier with the familial type. Can we dig into that a bit more?
Absolutely. It's a really active area of research. There's this gene, SDHD stands for succinylate dehydrogenase subunit D.
Okay.
Studies, particularly in mice, found that if you knock out this gene, their carotid body cells just stay switched on, continuously active, even when oxygen levels are totally normal.
Like the on switch is stuck.
Kind of, yeah. Think of the SDHD gene as part of the oxygen sensor. If it's broken, the sensor keeps signaling low oxygen, even when it's not true.
And that constant signaling
Could potentially lead to abnormal cell growth over time. It strongly suggests that mutations in this SDHD gene might be why some humans develop these tumors.
Okay, that connection is clearer now.
Yeah.
Before we get deeper into the tumors, maybe we should back up. What is the carotid body? What does it normally do?
Good idea. So the carotid body, believe it or not, is the largest single collection of chemoreceptor tissue in your entire body.
The largest. Where is it?
It's located right where your main neck artery, the common carotid, splits into the internal and external branches. Specifically, it sits in the tissue around the back surface of that fork in the road.
That's big.
Actually, no, normally it's tiny, sort of oval-shaped, maybe 5 millimeters long at most.
Huh.
It gets its blood supply from tiny branches, usually off the external carotid artery. And the information it gathers gets sent up to the brain through small nerve fibers from the glossopharyngeal nerve, ninth cranial nerve.
So what's it sensing? What's its job?
Its main job, its primary function, is sensing the partial pressure of oxygen in your arterial blood, how much oxygen you have circulating.
Okay. Anything else?
Yeah, to a lesser degree, it also keeps tabs on carbon dioxide levels and the blood's pH, its acidity.
And when it senses changes, say low oxygen.
Right. Specialized cells inside it, called type I gloma cells,
Yeah.
release neurotransmitters, chemical messengers.
Uh-huh.
These chemicals stimulate those little nerve fibers we mentioned, the ones from the glossopharyngeal nerve,
Which sends a signal where?
up to the brainstem.
Right.
Specifically, the medulla oblongata. That's a major control center for automatic stuff like breathing and heart rate.
Right.
The signals mainly affect the cardiopulmonary centers there. So if your oxygen drops or CO2 rises or your blood gets too acidic,
The carotid body tells the brain.
and the brain responds, usually by increasing your breathing rate, making you take deeper breaths, and also bumping up your blood pressure by constricting blood vessels.
Right.
It's trying to compensate. Got it. A critical little sensor. So now let's talk pathology.
Right.
What happens when a tumor grows there? What does it look like?
Okay, so these tumors are neoplasms, like we said. They're part of a bigger family called paragangliomas.
Paragangliomas, I've heard that term.
Yeah, they're tumors that come from specific cells related to the autonomic nervous system, the automatic control system. You can find these paragangliomas anywhere along that system, from your head down to your pelvis.
And carotid body tumors are just one type.
Exactly. And they happen to be the most common type of paraganglioma found in the head and neck area.
Are there others in the neck?
Oh, yes. You can get them in the middle ear, that's glomus tympanicum, or near the jugular vein at the base of the skull, glomus jugulare, or along the vagus nerve, glomus vagale.
Okay, so what does the carotid body tumor itself look like if a surgeon sees it?
Macroscopically, meaning just looking at it, it often looks a bit like the normal carotid body tissue. Kind of reddish-brown, maybe a bit rubbery feeling, usually well-defined, roundish.
Does it have a capsule around it? Interestingly, no, not a true capsule like some tumors do. And critically, they are highly vascular. Lots and lots of blood vessels.
Which sounds like a challenge for surgery.
Definitely is. Big consideration. As they grow, they tend to push the internal and external carotid arteries apart.
Ah, spreading the fork.
Yeah, exactly. It creates this look on imaging, particularly angiography, called the liar sign, because it looks a bit like the musical instrument.
Okay. And under the microscope, do the cells look cancerous?
Usually, no. That's one of the tricky things. Microscopically, the cells often look pretty normal, well-differentiated, resembling the regular carotid body structure.
So you don't see typical cancer signs, like weird nuclei or rapid division.
It's uncommon. Seeing things like nuclear polymorphism, weird shapes and sizes, or cells invading blood vessels, or lots of cell division, or areas of dead cells, necrosis, that's not typical.
So how do you know if it's malignant then? If it looks benign?
That's the million-dollar question, isn't it? You can't reliably tell malignancy just from the histology, just from how the cells look under the microscope.
Really? That seems unusual.
It is for many cancers, but it's characteristic of these and other neuroendocrine tumors. They can make various substances, often have granules with catecholamines like adrenaline.
But they don't usually release enough to cause symptoms.
Correct. They're usually non-functional in that sense. And they typically don't stain positive for chromaffin, which is a test that often indicates active hormone secretion in other paragangliomas like those in the abdomen.
So if the cells don't tell you, how is malignancy defined for CBTs?
It's defined by behavior. Clinical behavior. That's the key distinction.
Behavior meaning invasion, spread.
Exactly. Even if a tumor looks totally benign microscopically, it can still be considered malignant if it's aggressively invading the tissues around it, or if it spreads to lymph nodes, or more rarely to distant parts of the body.
So it's about what it does, not just what it looks like.
Nicely. Local growth can mean sticking to or wrapping around nerves and blood vessels. It can even grow right up into the base of the skull.
And spreading. Where does it usually go first?
Most commonly, if it spreads, it goes to the regional lymph nodes in the neck. Finding tumor cells in lymph nodes removed during surgery is diagnostic for malignancy.
So surgeons might practice-sized endowed limbs.
Only if they look suspicious.
Mm.
Routine biopsy isn't recommended. And if it metastasizes further, it can go to lots of places: brain, thyroid, lungs, bone,
Mm-hmm.
pretty much anywhere, though that's less common.
Okay, shifting gears slightly, how do these tumors usually show up? What symptoms might someone notice?
The absolute most common presentation by far is just a painless lump in the neck,
Yeah.
usually located just below the angle of the jaw.
And what does it feel like?
Typically firm, maybe smooth, or a bit lobulated, bumpy. And it has this characteristic mobility. You can often wiggle it side to side,
Mm-hmm.
but it feels fixed vertically, up and down, because it's attached to that carotid artery.
Can you feel a pulse in it?
Sometimes you can feel the pulse transmitted from the artery underneath.
Hmm.
And maybe 30–40% of the time, a doctor listening with a stethoscope might hear a whooshing sound from turbulent blood flow.
What if the tumor gets bigger? Does it start causing more problems?
It can, yeah.
Yeah.
If it grows significantly, it might press on things or start invading locally. That can lead to symptoms, though they're often kind of nonspecific.
Like what?
Things like localized tenderness around the lump, maybe a feeling of fullness in the neck, some numbness, difficulty swallowing,
Dysphagia.
right, or hoarseness if it affects the nerves to the voice box, maybe a chronic cough, or even tinnitus ringing in the ears.
What about nerve problems? You mentioned they can invade nerves.
Yeah, actual cranial nerve dysfunction isn't super common initially, but it can happen, especially with larger tumors. The nerves most often involved are the vagus nerve, the hypoglossal nerve,
Which controls
tongue movement, and also the cervical sympathetic nerves.
causing.
Rarely, it might cause Horner syndrome, drooping eyelid, small pupil, decreased sweating on one side of the face. People might mention dizziness sometimes, but clear neurological signs pointing to the brain are unusual.
And those hormone-secreting ones you mentioned are extremely rare.
Extremely rare. But if a tumor was functionally active, you might see symptoms from catecholamine-release headaches, palpitations, rapid heart rate, flushing, sweating, light sensitivity,
And maybe high blood pressure?
possibly. There are case reports where hypertension resolved after removing the tumor, suggesting maybe it was releasing small amounts of those hormones.
What about growth rate? Are these fast-growing?
Generally, no.
Hmm.
The classic picture is slow growth over many years. Someone might notice a lump, but not think much of it for a long time.
But not always.
Not always. Occasional reports describe more rapid growth. And while the risk of it actually becoming malignant is thought to be low, it's unpredictable.
Right.
Plus, they do tend to grow and can invade locally.
Right.
So putting all that together, the potential for invasion, nerve involvement, unpredictable malignancy, and the fact that smaller tumors are just easier and safer to remove.
Leads to the recommendation for early diagnosis and surgery.
Exactly. Most experts recommend tackling them surgically as soon as possible if the patient is otherwise a good candidate.
Okay. So if a doctor suspects a CBT, how do they confirm it? What's the diagnostic workup?
It really starts with the basics: a good history and a careful physical exam of the neck mass.
But lots of things can cause neck lumps, right?
Oh, absolutely.
Yeah.
The differential diagnosis is broad. It could be congenital things like cysts, inflammation, infection, other benign tumors, other malignant tumors, different vascular issues, those other paragangliomas we talked about. Lots of possibilities.
So imaging must be key.
Crucial. Radiographic imaging is essential both for nailing the diagnosis and for planning any surgery.
What kind of imaging? You mentioned angiography earlier.
Yeah, traditionally, conventional catheter angiography was the gold standard, injecting dye and taking x-rays of the blood vessels.
What did that show?
It gives amazing detail. Shows the tumor size, exact location, how vascular it is, where its blood supply comes from, whether it's encasing the carotid arteries, if there's another one on the other side, any underlying atherosclerosis. Really detailed map.
And you could do embolization then, too.
Right, that was another advantage, allowed for potential preoperative embolization to shrink the blood supply.
The downsides.
Definitely. Cost, the risks of the catheter procedure itself, bleeding, infection, even a small risk of stroke if a clot breaks off, and issues with the contrast dye, like allergies or kidney problems.
So what's used more commonly now?
Duplex ultrasound has become maybe the most important non-invasive tool. It uses sound waves.
What can ultrasound show?
It gives good anatomical detail, shows the blood flow within the tumor using color Doppler, helps measure size, assess if vessels are encased, checks for plaque. Plus, it's safe and much cheaper.
Limitations.
Yeah, it might not see the full extent of the tumor, especially if it goes very high up towards the skull or low down. The detail isn't quite as sharp as angiography, and it's a bit more dependent on the skill of the operator.
What about CT or MRI?
Yes. CT angiography and MRI MR angiography have largely taken over from conventional angiography for diagnosis, unless embolization is planned.
Why the switch?
They're not invasive, but still give really high-resolution images of the anatomy and the blood vessels, often better than ultrasound for seeing the full.
Better view of the whole neck.
Exactly. Better view superiorly and inferiorly, and you avoid the risks of catheter angiography. Plus, you can do 3D reconstructions, which are great for planning surgery.
Any risks with CTA or MRA?
Well, CTA uses X-rays, so there's radiation exposure, and it uses contrast dye, so the same allergy and kidney risks apply as with conventional angiography.
And MRA?
MRA avoids radiation, but the gadolinium contrast agent it uses carries a small risk of a serious condition called nephrogenic systemic fibrosis, but really only in patients who already have significant kidney failure.
Okay. Now, the source material was very clear. No needle biopsies. Why not?
Critical point. Because these tumors are so vascular, sticking a needle in carries a really high risk of causing major bleeding.
Leading to?
Hematoma, a big collection of blood, or even a pseudoaneurysm, like a dangerous bulge in the artery wall. Plus, you could easily injure nearby nerves or vessels.
And it's not necessary anyway?
Generally not. The imaging nowadays is so good, especially CTA and MRA, that the appearance of the tumor is usually characteristic enough to make the diagnosis pretty confidently without needing a tissue sample.
Got it. The outline also mentions the Shamblin classification. What's that?
Right, the Shamblin classification. It came out of the Mayo Clinic. It's a system to categorize these tumors based on how involved they are with the carotid arteries. Really practical for surgeons.
How does it work?
3 groups. Group 1, smallish tumors, easy to separate from the artery walls.
Okay.
Group 2, bigger, more adherent, starting to partially wrap around the vessels. Surgery gets trickier.
And group 3.
That's the toughest. The tumor is intimately stuck to and fully encases the internal and external carotids. Makes removal much more complex, often requiring vessel reconstruction.
And modern imaging can tell you the Shamblin grade beforehand.
Usually, yes. CTA or MRA can give a very good idea of the Shamblin stage, which is hugely helpful for surgical planning. Lets the surgeon know what they might be up against.
Does it predict risks too?
It gives some idea, but some recent studies suggest that maybe the actual volume of the tumor and how close it is to the base of the skull might be even better predictors of certain risks.
Like what risks?
Things like major blood loss during surgery, needing a transfusion, and, importantly, the risk of injuring cranial nerves during the dissection. Closer to the skull seems riskier.
Okay, that makes sense. So let's talk treatment. We've established surgery is the main approach.
Right. Surgical resection, complete removal is the mainstay.
And the reasons for doing it early, again, were?
Easier removal when small, lower complication risk, preventing local invasion into nerves or the skull base, and eliminating that unpredictable, albeit low risk of malignancy down the road.
So unless the patient is too frail for surgery.
Or has a very limited life expectancy for other reasons, yeah. The recommendation is generally surgery as soon as it's diagnosed and the patient is ready.
What about radiation? You mentioned it's controversial.
It is. Its role is debated. Some use it as primary treatment, some as an add-on after surgery, especially if removal wasn't complete. But the evidence is mixed.
Are CBTs sensitive to radiation? Do they shrink much?
Traditionally, they're considered relatively radioresistant, meaning radiation doesn't tend to make them disappear. It's more often used to try and stop or slow down their growth.
Any downsides to radiation before surgery?
Potentially, yes. Radiation can cause scarring, fibrosis in the tissues around the tumor. That can make the later surgery technically harder, more difficult to dissect things cleanly.
So radiation is usually reserved for
patients who are poorer surgical candidates, maybe due to age or other health problems, or for tumors that are just too big or invasive to remove completely, or if a tumor comes back after surgery.
And chemotherapy?
Unfortunately, no. There aren't currently any effective chemotherapy options for carotid body tumors.
Okay. So focusing on surgery then, what preparation goes into getting ready for the operation?
It's pretty comprehensive. Starts with assessing the patient's overall health, just like for any major vascular surgery. Looking at heart, lungs, kidneys, optimizing everything.
Since it's usually elective, right, you have time to get things tuned up.
Exactly. Minimize risks. Then, getting that high-quality imaging CTA or MRA usually is crucial. Know the size, the extent, the Shamblin grade. Check for tumors on the other side.
What else?
Need to document any pre-existing nerve issues, any hoarseness, tongue weakness, Horner syndrome. Get a baseline. And although it's rare for them to be functional, if there's any suspicion symptoms, like palpitations, high blood pressure spikes, you do lab tests. Check urine or blood for catecholamines.
Why is that important?
Because if those tests are positive, it might mean the patient also has a pheochromocytoma, usually in the adrenal gland.
Another hormone-producing tumor.
Right, and those need to be dealt with first, before tackling the carotid body tumor, because they can cause dangerous blood pressure swings during surgery.
Good point. What about that preoperative embolization again? Is that standard prep?
Still controversial. Some surgeons like it, especially for bigger tumors. Chamblin the second or third.
Remind us what it involves.
Going in with a catheter via angiography, finding the tiny arteries feeding the tumor, and blocking them off with gel foam or coils.
The idea being?
Reduce blood flow to the tumor, hopefully making surgery less bloody, maybe faster, maybe fewer complications.
But does it work?
The studies are mixed. Some show benefits, others don't find a significant difference. And it's not without risks itself.
Like stroke?
Small risk, yeah. Plus, it's another invasive procedure, adds cost, some patient discomfort. So it's really a case-by-case decision between the surgeon and patient, not routine for everyone.
Okay, finally, the operation itself. What are the key concerns and steps?
Well, the biggest immediate concern, given how vascular these are, is bleeding. Massive hemorrhage is a real risk if things aren't controlled carefully.
And the nerves and vessels nearby.
Exactly.
Yeah.
The tumor might be stuck to them, even wrapped around them. So avoiding injury to the carotid arteries, the jugular vein, and crucial nerves like the vagus, hypoglossal, laryngeal nerves, that's paramount.
Requires careful planning based on the scans.
Absolutely. Knowing the anatomy, the tumor's relationship to everything else, surgeons might use special tools like harmonic scalpels or bipolar forceps that seal blood vessels as they cut to minimize blood loss.
Anesthesia, general, you said.
Almost always general anesthesia. It gives the best control for what can be a long, delicate operation. Better airway management, less patient movement.
And monitoring the brain during surgery?
Often, yes. Especially if there's a chance the internal carotid artery might need to be clamped or reconstructed. ED monitoring is common.
Or using a shunt.
Right, placing a temporary tube, a shunt, inside the carotid artery to keep blood flowing to the brain while the surgeon works around it. Some surgeons use shunts routinely for these cases.
Why routinely?
It can also help control bleeding from the external carotid artery branches that feed the tumor, potentially making the resection cleaner.
Okay. What about positioning in the incision?
Pretty similar setup to a standard carotid endarterectomy. Patient on their back, head turned away from the side of the tumor, maybe a shoulder roll to extend the neck a bit.
Head tilted up slightly?
Yeah, often elevated 10-15 degrees, helps lower venous pressure, reduce oozing in the incision.
And the cut.
Usually a longitudinal incision along the front edge of the big neck muscle, the sternocleidomastoid, centered over the carotid bifurcation.
Might need to be longer for big tumors.
Could be, yeah. Might extend up towards the ear or down towards the chest. For really high or extensive tumors, sometimes more complex exposure is needed, maybe cutting across behind the ear, detaching muscles, even temporarily moving the jawbone.
Wow. Okay, so once the surgeon is in, how do they actually get the tumor out?
It's a step-by-step dissection. First, retract the sternocleidomastoid muscle, open the carotid sheath, the tissue layer around the vessels.
Find the jugular vein?
Right. Usually tie off the common facial vein where it drains into the jugular, then gently move the jugular vein aside to get better access.
Then identify the nerves.
Critically important. Find and protect the hypoglossal vagus laryngeal nerves. They might be stretched or pushed aside by the tumor.
And then get control of the arteries.
Yes. Carefully dissect around the common carotid artery below the tumor. Get enough length free so you could put clamps or a shunt on if needed.
Find the vagus nerve again.
It's usually right there, often running between the carotid artery and jugular vein. You need to separate it gently, then dissect upwards along the artery, separating it from the vagus until you get above the tumor and can mobilize the internal carotid artery.
Where you might encounter the hypoglossal nerve.
Exactly. It often loops forward over the arteries high up. Have to be super careful dissecting it free. The goal is always to save the internal carotid artery if possible. It's usually just pushed aside, not truly invaded. Then dissect it down the inner side of the internal carotid, back towards the bifurcation. And finally, free up the external carotid artery all the way around.
Now, the actual tumor removal depends on the Chamblin stage, right?
Precisely. For a Chamblin the first, small and easily separable.
You might save the external carotid.
Possibly.
Right.
You carefully dissect on the tumor's surface, find the little feeder vessels coming off the external carotid, tie them off, protect the nerves, and show the tumor out.
But if it's stuck to the external carotid, Chamblin the second.
Then you usually have to sacrifice the external carotid artery. Divide it near its origin, use the stump as a handle to help rotate and dissect, and remove the ECA along with the tumor.
And for Shamlin III, where it encases everything.
That often requires removing the bifurcation itself, maybe parts of the internal and external carotids too. Then you have to reconstruct the internal carotid artery, usually with a graft, either a synthetic tube, like PTFE, or sometimes a piece of the patient's own vein. If you're using a shunt, it can run through the graft while you're sewing it in.
And heparin if you clamp arteries.
Oh yes, systemic heparin to prevent clots if the main arteries are clamped.
What if nerves are stuck to the tumor?
You try your absolute best to dissect them free, preserve them. Sometimes you might need to carefully split parts of the tumor using bipolar cautery to control bleeding while peeling the nerve off.
Then close up.
Yep. Irrigate the wound thoroughly, check meticulously for any bleeding points, then close the tissue layers. Drains aren't usually needed, but might be placed sometimes.
And after surgery, what's the recovery like?
First thing is a neurocheck as they wake up. Then close monitoring and recovery blood pressure, neurostatus, watching the neck for any swelling, which could mean a hematoma.
Which is an emergency.
Can be, yeah, if it compresses the airway.
Right.
Also watching for any stroke symptoms or signs of new nerve injury.
How long in hospital?
If things go smoothly, often just 24 to 48 hours. Pretty quick turnaround for uncomplicated cases.
Follow-up needed.
Yes, long-term follow-up is recommended. Recurrence is rare, but it can happen, so periodic checks are a good idea.
So what are the results generally like? How risky is the surgery?
In experienced centers, the outcomes are generally excellent. The risk of dying from the surgery is very low, less than 0.5%.
And major complications. Stroke, nerve damage.
Also very rare, especially for smaller, benign-looking tumors. The biggest risks are probably bleeding or hematoma if vascular control isn't perfect.
And nerve injury.
That risk is definitely higher with bigger tumors. One large study reported cranial nerve injury in about 24% of cases overall.
Wow, 1 in 4.
But remember, that includes any temporary weakness. And we know now that tumor volume and how close it is to the skull base are probably better predictors of nerve injury risk than just the Shamblin class.
Is the nerve damage usually permanent?
Thankfully, no. Most cranial nerve issues after the surgery are transient. Function usually recovers over weeks or months.
And overall, complications are often preventable.
To a large extent, yes. Good planning based on imaging, meticulous surgical technique, and surgeon experience make a huge difference.
Okay, let's try to wrap this up. What are the absolute key takeaways for our listeners about carotid body tumors?
All right, so number one, they're rare. Neoplasms, tumors arising from the carotid body.
Usually show up as a painless neck mass.
Right. Typically slow-growing, usually benign looking under the microscope, but they can be locally aggressive.
And malignant transformation, while rare, is unpredictable and defined by behavior.
Exactly. They are highly vascular lesions. Imaging ultrasound, CTA, MRA is key for diagnosis and planning.
And treatment.
Early complete surgical removal is the standard of care.
With low risks and experienced hands.
Generally, yes. With good planning and technique, mortality and major complication rates are low.
Okay. Leaves us with a final thought. Considering how vital the carotid body is for sensing oxygen, it makes you wonder, doesn't it? What other subtle impacts might rare tumors in these seemingly small, specialized structures have on our overall health? Things we maybe don't even recognize yet.
That's a fascinating question. And the whole idea that malignancy here is defined by behavior, not just cell appearance. It really challenges our usual categories for cancer, doesn't it? What does that imply for how we understand and classify tumors more broadly? Lots to think about.
Definitely food for thought. If you found this deep dive into carotid body tumors interesting, maybe you'll want to explore more about vascular surgery or other rare conditions.
Hope you found it useful.
Join us next time for another exploration here on The Deep Dive.